Thanks for having me tonight, guys. Like Aaron said, this is a mastering webinar. So this whole slide deck's about 200 slides. I went through it this afternoon. I spliced a lot of stuff I thought was more like basic intro stuff. So this is your first time kind of digesting this. I might talk over your head and you might be missing some stuff. So go back and watch some other stuff, hopefully fill in the gaps. But I'm going to be skipping over some basic stuff tonight. Webinars are tough. Webinars are tough because I'm talking into my screen. I don't have you guys to interact with like an actual course. So it's hard to say what you guys want out of this. So I'm going to do my best to cover some basic stuff, a bunch of cases, and then some common questions, issues that kind of arise on the Facebook groups and just things like that. We'll open this up for like 20 minutes at the end for questions. And if I don't get around to everything or you guys have questions, Jordan, Aaron, Chris, all those guys are available. I'm available. Just reach out. So let's give this a whirl. So, all right, real quick, me. I'm from Pennsylvania. I grew up in Pennsylvania. I've lived in Pennsylvania my whole life. I've never left the state. So, went to Temple Dental School, went to residency at Temple, and currently I am the program director at Temple University Hospital's pedo program in Philly. That's our beautiful city of Philly, and those are someone's dentures that they left at the bus stop. At any rate, so. No disclosures. I do help the guys out at NuSmile and NuSmileTech with some ideas and feedback. And Dental High Tech is the French arm of this thing. These guys kind of got the Sew-In, the Sleeper One, all these things off the ground. And then NuSmile kind of integrated those into the U.S. market. So that's why we're fortunate to have them at our disposal and we can utilize them. So. Also, these are your people throughout the states. If you ever need anybody, remotely we're always available, but local, if you need someone local, there's plenty of people. Sarah Werb's got the whole entire country of Canada, so she's very busy. No, she's not the only one up there, but we got a bunch of people on the East Coast, Northeast, Midwest, down in Texas. Lucero and Josh are kind of running the whole West Coast there, so they're kind of busy, but reach out. Everyone is really receptive and open, and we all have varying degrees of experience. And like Patrick and myself, we work in residencies, so we see a lot of the new users, and a lot of these other guys have worked out in the field. So, all right. So again, NuSmile, been around for a very long time. Lots of things they've put out on the market, and as you can see in the last, basically past COVID, things have been cooking. So between putties and liners and the BioFlex, tonight's the whole thing with Sew-In and Sleeper One. I'm going to talk about the Sew-In almost exclusively just because that's what we have at the program for simplicity, but the Sleeper One's not much different. It's the same technique, and obviously there's more stuff to come down the road. So as far as overview, I will talk a little bit about bone morphology and some anatomy pieces that I think are just highlights that really need to be driven home again. We'll just touch on some local stuff. There's some important things in there we talk about. Talk about the needles quick. They are special, unique needles. They are, I think, a huge piece of why the device is amazing. However, without the needles, the device is not as amazing as it could be. So you need both these components to really work well. And my whole goal is I want to do a bunch of cases. And like I said, I have about an hour to do all these things. So it's a lot. And then we'll talk about just some other issues, problems, common themes that come up, common issues. Like I said, we can go over those again in the last 20 minutes if you want. So again, you basically have to take all these things into consideration to really master this. So if you start on the right there, picking the right case, you're going to have a lot less headaches. Knowing how to set the device up, you have to know that to do the onboarding. If you haven't done it, make sure you do it. And it's never a bad idea to either listen to what we're talking about tonight so I can refresh your memory on some stuff, or sit back and go through those onboarding things periodically if you kind of start to have issues, especially with new staff you onboard. Like the last thing you want is, for them to go screwing up one of your devices for something silly. The needles, we'll talk about the local. Septo is, what's commonly recommended for use. I use a lot of lidocaine with this thing too. So again, I have really good results too. Yeah, there's times and places I'll use the Septo without a doubt. But if you're totally not on board with septo and you still have some reservations for whatever, I use plenty of lidocaine, so it does work. We'll talk about bone anatomy. There's a lot of unique situations we might come across too of, troubleshooting. So, I'm assuming everyone on this call is a doctor, and you guys all realize we all have to troubleshoot stuff. It's not just everything's straight cookie cutter, just by the book. There's a lot of thinking outside the box and trying to troubleshoot stuff. So that's where a lot of the sometimes the frustration comes in, because it's not always just the same repeated things in over and over. And the big thing I find from my perspective, the angulation and insertion is sometimes the hardest thing the residents from my perspective have. But with some time and some patience, they do get a hold of this thing. So in the end, again, this is hopefully the place where we all find ourselves, learning how to do this. This is just, you guys have done this already, so I probably can take this slide out even, but just to talk through this. So we use isolate almost all the time for most of the patients to gather any of that local that right there kind of just drips or squirts out. You will have a drop or two at all times. If you're not using an isolate, I always tell folks to take a 2x2, just open it up and wrap it around that area, acts like a sponge, hopefully to catch any local you're dripping. But, angulation here, was it the perfect angulation? No, I probably could have been, rotated back a little more, but either way, I was in the bone and we got what we needed to done. So this is the whole goal of trying to, master this in this way. You can see on the carpial too, that's lidocaine too. So again, we don't always use septicaine. So it's, it's not an absolute, but yeah, it'll probably work a little more predictably. So at any rate, again, talking about local, again, most of us have been practicing for a while. We've all been trained doing blocks. We've all been trained doing all these other techniques and infiltrations. Again, I'm sure as you've practiced more and more and more, you've gotten more successful. However, there are some kids and some times, whether it's a patient need or whether it's just I cannot get this person numb, whether it's a tooth, whether it's a hypomineralized tooth, a hypoplastic tooth, whatever you want to call it, that's a problem. Those things are always give most of us some headaches. Some of our special needs kids who really don't tolerate soft tissue anesthesia. Again, this is another great tool to minimize the usage of that. So, and obviously getting kids numb, we're all different. We're all taught in dental school. Everyone's anatomy is the exact same because that's what Netter told us. But the reality is we're all very different. That's why we don't always get kids numb. So, again, prime example is something like this where, old school, we used to block people all the time. And, most of the time we got it right. However, sometimes you get an oddball, your mylohyoid nerve branches off way high and then innervates your teeth. So we start to do, which is the picture over on the right here, these extra injections for mylohyoid nerves. So again, with the SOAN, with the Sleeper One, you've kind of eliminated all these other extra nerve innervations because you've gone right to the source, you've gone right to the tooth, or you're parked right next to the tooth. So all these other extra nerve innervations usually get anesthetized with the intraosseous technique. So you don't have to worry about all these extra, injections. Again, these are the kids that drive you nuts. They act like they're numb. They feel like they're numb. They're telling you everything they're numb, but in the end, they probably have some oddball nerve that's innervating their tooth. That's why they're not cooperating. So again, with the SOAN, you guys can eliminate that stuff. So hopefully you've seen that happen if you've been using it. So I tried to pull one or two little articles here I found. So the take home message was kind of like what I talked about here in the previous slide was the minimization of the soft tissue. I would say soft tissue anesthesia is not an absolute, like it never happens. You will get some tingling with these kids. You will see, and they'll give you some feedback that they do probably feel their lip is a little numb, but it's absolutely something they can feel. So if they would decide to start to bite on their lip or do anything like that, they're definitely going to know they're doing something that's harmful or hurts or it's uncomfortable, and they will stop. So when you look at this, this article that came out, they split basically 50 kids. They did conventional infiltrates with septo, and about 15 out of 53 kids had some soft tissue trauma. With the Sleeper 1.5, they had about half as many. So they did still have some. One of our residents just did their research presentation on this, and they had about 40 kids, I think, in their sample size, and none of them had any soft tissue trauma reported by the parent after 24 hours. So Again, they will have some numbness and some tingliness, but not to the point where it's numb to where they're probably going to cause any harm to themselves. So, which is again another great thing. Again, we can talk about the bone. You guys know how this all works. This cortical bone is really thick. The whole goal is to get through this cortical plate. So again, if you guys, we'll talk about this a little later. So if you don't know if you're in bone, what I tell the residents all the time is you don't know if you're in, you didn't have that nice pop through, that nice, satisfying kind of penetration in the bone, try to tug back on the unit. And if you feel some tug back and you're stuck, you're in the bone. You probably had some softer bone that needle was so sharp it just slid right into, and you didn't have a lot of that like resistance, but now coming out, you're having resistance. So, and when we administer the local, you really got to keep an eye on, I do three things. One, where the needle's at, make sure it's staying in place. Also, there's no any kind of fluid coming out of the sulcus. There's nothing else welling up or swelling up around the area. I always keep my eye on, and then I trace my eye up the unit, keep my eye on the actual carpial, see how much I'm delivering. The unit does make a beep, which you guys may or may not have heard, but with nice light on the kid, the talking, us just running our mouths and everything we do to keep the kid busy, we don't always hear that stuff. And then I always keep an eye on the lights too, just to make sure I'm not having too much resistance. There were some questions that came up on the Facebook group about pain and discomfort with some extractions. I mean, you got to remember, your C fibers are still going to feel some pressure. So if you have a kid that's, he's numb, but they're going to feel pressure still. And it's the last thing and the most difficult thing to actually get rid of. So, and you got to learn how to read your kid. And I think all of us probably on this have been doing this long enough that you know which kids are going to be difficult and kind of tricky, and which ones are a little dramatic. But just be advised, you're going to feel some pressure, especially with an extraction. So. I threw this slide in here just so everyone understands just the thickness of what we're trying to get through. So most of the time the attached gingiva, it's about 1.5 millimeters thick. So we're talking usually these 9 millimeter needles we use. Those are the ones we typically use for the IOs. So you have about 1.5 millimeters of gingival thickness, another 2.5 millimeters of cortical plate. And then we want to make sure we're about 2 or 3 millimeters into the bone, like into the trabeculated area. So do the math. That's about a 6 to 7 millimeter, penetration from the outside into the trabeculated bone that we need to be in. So, in the end, you should have about 1, 2, probably 3 millimeters of needle still showing. So, then God forbid, the kid moves, you do something inadvertently and it breaks off. You do have that 2 or 3 millimeter little piece of needle out that, God forbid, you separate it. It's going to be stuck in the bone, so it'll be pretty easy to move and remove, but. Just don't ever bury it to the hub, because then it's going to make it really difficult. God forbid that happens to you. So you don't need to do it. Local, let's talk about local quick. So the device, again, doesn't change anything about the kid's medical history, about their what local they can tolerate or whatnot. So I think Steve Greenleaf today put it on. That's one of his kids. He had long QT. So one of his kids had long QT today. He ended up using bupivacaine, got the kid numb on both sides, bilateral on the bottom. Again, worked great. Again, trying to block with bupivacaine's fine. It only works for about 20 to 30 minutes. That's the problem. But so again, kids with long QT, cardiac issues, again, you have to default and use this. So you can use this with the device. It's not a problem. Lidocaine, again, like I said, we use a fair amount of lidocaine. We do use plenty of Septicaine, but again, just to prove that you guys can use this, lidocaine is completely fine to use. So the nice thing with the lidocaine sometimes too, it will last a little longer. So if you do have a procedure that might need some, longevity to it, the lidocaine actually might last a little longer if you need that piece, because it's going to take longer to break down versus Septicaine. So if you have something that could be hypothetically more painful later, either A, pre-med the kid, B, med the kid with some Motrin Tylenol on the back end immediately after, or the use of the lidocaine sometimes will prolong the breakdown and keep that kid numb in whatever site or whatever procedure you may or may not have done. So just, keep that in the back of your mind. Septicaine obviously comes in two flavors. One's the 1 to 100, one's the 1 to 200. Again, in the US, really not supposed to use this under kids under 4. Canada's a little different. You guys do what you want. I don't use this under kids under 4. We use the lidocaine and it works just fine. Half-life is much shorter for this. So again, if you have a painful procedure or something that could be a little tender, a little sore afterwards, this might wear off a little quicker. So I would make sure you get your kids some, maybe pain meds on board soon after, or maybe even pregame it with them. Just to kind of think about that. Depends what you're doing. If you're doing some basic restorative stuff, you're probably fine. Some surgical stuff, you might want to do something else, either lidocaine or make sure you have some other meds on board just so they are comfortable. Again, the big difference, the 1 to 100, 1 to 200 is just the epi. One's going to obviously diffuse out more, the 1 to 200 versus the 1 to 100. So if you're trying to work on 2 or 3 teeth in the quad, the 1 to 200 is your friend. If you're trying to stay in 1 to 2 teeth right in an area, 1 to 100 is probably a better option. Otherwise, not a big difference. That's your 1 to 200, just a different colored band. So, real quick too, just little things. Again, being in a hospital setting, we see a fair amount, a handful of kids with sickle cell. So just if you have any individuals with sickle cell in your office, just avoid the septicane. Take it easy with that. And then obviously, like I talked about before this, anything with any kind of epi issues, cardiac issues, whatnot, hypothyroid issues, got to make sure you're using anything without epi in it. So. Again, you can use a lot less with this. If you want to get yourself in trouble and you get yourself in a lawsuit, the best way to do that is to overdose a kid on local anesthesia. So don't do that, please. I'm serious. This is just goes to show this is a bunch of claims that were from insurance companies. So a lot of these kids, if you read down here, 7 out of 17 of these cases had local overdoses, and they were not just a little bit. They were anywhere between 100%, 120% basically of what a kid was able to have, up to almost 3.5 times of what their recommended dose was. So again, it's nice having the SOAN, having these devices, these units, because you don't have to typically utilize very much local. So these are the people, the individuals that probably just kept pumping local in because they couldn't get somebody numb. So again, this is something hopefully no one else will find themselves in ever. And the great way to avoid it is obviously calculate your local, but also use a device like this where you don't need to keep dumping local in. So, all right, topical. Do you want to use topical? I tell all the residents, when you guys start to use this, when you're a novice at this, use the topical, because just make everything easier. Again, this is an example too. We kind of put that cotton 2x2 in there just to kind of act like a little sponge to suck up any local that kind of drips out. The residents sometimes find that they'll take their foot off the pedal, they'll come out. There's some back pressure with this device. So sometimes you get a couple little drops leaking out. So I sometimes have them just grab that on the 2x2, the cotton there. Or if you have an isolate in, that's fine too. But hopefully that minimizes the taste, because that'll set the kid off by itself. As you guys get advanced, probably most of you folks here, you may or may not want to use topical. Use local. Use the topical. Again, it's really based on the kid's anxiety level. So if the kid's pretty anxious, I would probably use it. Just to try to make everything as smooth as possible. But again, it's not a necessity or a must. So. The needles, again, you guys are familiar with this. Again, just to reiterate why there's a difference. The traditional needles we probably all use for the past years or decades were these tri-beveled needles, so they kind of tear. These Effitech needles are double beveled, so you don't have to actually advance them when you push in for that stage 1. All you have to do is just press down a little bit. And as you press down, it will advance a little bit more for your stage 1. So different sizes. Again, I think we exclusively keep the 9mm at our office. We have one box of 16mm and one box of our 35mm that we use if you wanted to use a block, but we never really do. Just don't need to. So, again, if sometimes, the residents always ask me, like, well, how many times can I go into the bone? How many times can I go in? So rule of thumb is, if you're doing a side, I always tell them, do the bottom first. Do the mandible first, because you need the sharpest needle to penetrate through that thick cortical plate. If you can get that on one shot, you probably can get upstairs and do the same thing. Do the maxilla with one shot too, with the same needle. If you sit there and poke around and bang into the mandible 3 or 4 times before you get in, or 2 or 3 times before you actually get in, then you probably need to change the needle out before you go back upstairs. Otherwise, that kid's going to have some discomfort, and then you're going to get frustrated because you have a somewhat blunted needle now you're trying to penetrate through bone. So just be aware of that. So if you guys can get in pretty easily, keep the needle on there. If you find you're having some frustration, some angulation issues, don't be afraid to change the needle out. They cost like 9 or 10 cents more than a regular needle, so it's not going to break the bank. Um, Excuse me, I got allergies here, so we're starting to get in pollen season here in Pennsylvania, so it just irritates me. Assembling the device. Please, please, please make sure you double check before you grab this from your assistant or whatever. Make sure your assistants know how to do this stuff. Pull them aside at lunch. Just say, hey, let's sit down for 5, 10 minutes. Let's go over this thing. This thing's my baby. You know, it's not cheap. Let's take care of them. So just make sure you don't over tighten these canisters, okay, the little clear things. And then here in this picture, you can kind of see this one didn't get put in just right. So as you can imagine, as that piston starts to come out and come down, it's going to stop at some point because it doesn't have a straight path. So always double check this stuff. Always double check the pedal too, just to make sure the pedal and the unit are communicating. We just have one sew-in we keep in the office just to make it easier. Some of you guys I know have 2 or 3. So again, just remember those pedals and the units are married together. They don't really cross talk. So just make sure you have the same ones, they're matched up. Again, this is just stage 1 stuff. You guys know how to do this stuff. It's more just not always pressing and going too far. You got to make sure you don't go too far with this, because if you hit the periosteum before you get to stage 1 started, you're going to have some reactions from your patients. So you just really want to just be in the very, very superficial part of the gingiva before you get in there. So you guys are probably good with the pedals here. So, all right, I got about a half hour, 40 minutes. So I'm going to scoot along here to try to get to some cases, because hopefully that's the real practical stuff that you guys are hopefully looking for. Stage 1, stage 2. This is the same video I showed you probably before. So again, you can kind of see that middle picture. There's about 2 millimeters of needle still showing. That's what I want. I know at that point I'm probably in enough, and then the way I double check it, I can, if it didn't have that kind of pop, I'll do a little tug back on it. And if it's pretty locked in there, I'm pretty confident I'm in bone. But again, always keep an eye on the place where I'm starting to inject that, and just make sure there's nothing coming out the sulcus. For some reason, not in the PDL. For some reason, I'm not I missed something. But using that tug back gives me that confirmation that I'm in bone. So, so again, the old juice box. Again, you may have felt this, you may not have. Sometimes you will, sometimes you won't. And again, just make sure you feel that tug back. That's the biggest thing, I think, to kind of just, triple check, quadruple check that you guys are in a good place. Again, you guys are most likely pretty aware of this. Upstairs, you're going to get a little more diffusion, a little more range with your local. Wherever you guys inject, you'll probably get about, solid 2 teeth posterior, solid 2 teeth anterior. Downstairs, probably a little different. You're probably shooting for about 1 tooth posterior and probably a good 2 teeth anterior to that. So again, this is based on a lot of things. It's based on how much local you put in there. It's based on, did you use septa 1 to 100, septa 1 to 200? So you have to understand what you're trying to accomplish here, and then you can kind of pick and choose maybe which local you decide to use based on what you're trying to accomplish. So again, we talked about soft tissue stuff previously. You still will get, in my opinion, some lip paresthesia. So again, you're still going to feel the lip. It's going to feel a little tingly. It's going to feel a little weird. But you're still going to have the ability to know it's still there. So if you have a kiddo that's starting to bite on it or prone to do that, they probably will not do that, because they're going to know they're biting the lip and they can actually feel what they're doing. So again, no limitations too. I'll talk about this in one of the last slides. But again, if you're trying to take something off someone's tongue, you're going to have a really angry patient, because their tongue's not going to be numb. Their lip's probably not going to be numb. So if you're taking off the mucus seal, you're going to have to do an infiltrate. You can't just do an IO. If you're taking something off their tongue, you're dealing with their tongue, you have to go at whatever you're trying to get accomplished. So, and then the same thing with the with especially the anteriors too. The attached gingiva is going to be covered, but anything that's above that attached gingiva, the unattached gingiva of the lip, that's usually not numb. So if you're working up there, make sure you're doing some other adjunctive local measures to make sure they're numb. Again, we won't see this as much. This is something we've seen, probably way too much and probably even less than really happens, because I feel like some of these kids end up going to the hospital or go somewhere else. They think it's some allergic reaction, but in reality is their kid just sucked on or bit their lip really bad. And you even get the cheek biting here, like in this picture on the bottom left. So the kids get numb, they just bite their cheeks. So they don't swell up, but it's sore. So, and that's the kind of stuff that, should be avoided and shouldn't really happen with this device. So hopefully none of you have seen this since you've been using this. If you guys are having any issues too, if you need you have a new hire on board, you have a new associate, they can't get to a course, they can't get to a hands-on thing, go buy some chicken bones, strip all the, the meat off of them. And what you can do at the very end of that bone towards the knuckle, play around with that. That's going to really mimic, a softer, younger kid's bone. It's a lot easier to penetrate. As you go down that shaft just a little bit, you're going to feel bone that's a little more dense, a little more difficult to get through. That's going to be like your teenager. Another great way, if you have the access and the ability, if you can get to the OR and you can sneak this in the OR, get into the OR, get in the OR with you and practice on those patients in the operating room. It's amazing. So if you have a surgery center, if you can get them in there, if you can utilize it, it's a great way to really, really learn on patients that are asleep. But again, obviously go through the right mediums and make sure you're not doing anything you're not supposed to be. But all right. SOAN, again, you guys are probably either using the SOAN. Hopefully anybody's had some hand issues, ergonomic issues, those have kind of subsided or things are a little less stressful on you. Again, it's one of my old residents, so she's like in some kind of contorted headlock situation there, so that doesn't look comfortable at all. Again, just a really quick overview. I tell the residents, anytime we do this, we always line that D up with the lights, so it makes it much easier to see, and I can see what I'm doing a lot easier. So again, if you're using a sleeper 1.5, it's not as critical because that light goes the whole way around, so you don't really need that situation. But with the SOAN, you really, I find it much easier to line that D in the needle up with the lights to keep everything in line. So again, you guys know how to use these pedals. Next slide's a little more important. So what happens if you're like me and you have a size 14 foot and you're just go step on both pedals? What's going to happen? Well, the system's smart enough that you actually just go back to the slowest speed. So don't think that, you're delivering both or you're delivering phase 2 or the faster speed. So if your foot inadvertently hits both pedals at once, you're actually going to deliver the slowest speed. So just kind of look back down and then just kind of reposition your foot. So it's happened before. All right. Again, you're all familiar with the lights too. Like I said, when I'm administering, I'm making sure I'm looking at the needle, I'm looking at the carpial, and I'm looking at these lights. So again, the system's smart enough when it gets to 3 or 4 lights, it's going to tell you it's not happy. When it gets to 4 lights, it's turning itself off. So at that point, you start to see 2 and 3 lights start to take, back off. You're probably either stuck against a wall, you're up against a bony whatever. Back out that needle a millimeter or 2, and if the lights start to go back down, you were stuck there and you figured it out. So resetting these. Again, you guys know how to do all this stuff. So again, you can do option A, hit the button there, or you can do it in the pedal as well. Make sure your staff knows how to do that. They don't just take this thing apart. Otherwise, you'll end up with a bent, broken plunger. So, and that's what happened here. So Andrew had a bent, broken plunger, wasn't too happy about it. So again, make sure you teach your staff, make sure you take the time to show them how to do this stuff. Otherwise, Jordan, Aaron, and Chris won't be happy. How do we take care of this device? Again, this is just a lot of repeat stuff. I'm going to get to this cases here in about 2 minutes. Make sure you guys are wiping these with Cava wipes. Don't use alcohol. Alcohol will dry these out. Don't drop the device. Don't throw it. Don't do those things. That's bad. The biggest thing too, we don't charge ours at all during the day. We leave it out. It'll go a whole day without being charged. If you throw it back on the charger for some reason, and you wipe it off with Cava wipes, please, please, please make sure you dry or have a dry contact on those little gold, silver bottoms of the device when it touches the prongs in the charger. Otherwise, you're going to short it out and cook it. So just make sure, just like electricity and water don't mix, same thing. Cavicide and electricity don't mix. So just make sure those metal prongs at the bottom and the faces where they meet are dry. So. Also, these canisters, make sure you don't throw them in cold sterilization. This is what will happen. Cold sterilization does not do well with these canisters. So again, this is all onboarding stuff, but again, it bears repeating. So make sure you guys are putting these through regular sterilization, not cold sterilization. They will break down if you do cold sterilization. Sleeper one, again, same stuff, same things going on here. Again, another little setting, a little faster mode if you want that. But again, if you have sew-in, you're not going to have that. So. Again, there's only one way to reset the pedal too. So that's a little easier. What happens if you have both of the sew-in and the sleeper one in your office and you go to grab a canister, you don't know which one's which? So we only keep one in the office, so that makes that easy, but some of you guys may have both. Real quick, way I remember it, sew-in, 4 letters. The tube is longer. So 4 letters, 4 letters. Sew-in's 4 letters, long is 4 letters. So if you grab a canister, the long skinny one is a sew-in, sleeper one's the shorter one. So, and then if you guys have been using this for a while, I don't know if you've changed your canisters out at this point, but the tops of what they start when they have that nice kind of like opalescent, clear, bluish, and then as they start to wear and tear and crackle and start to go through autoclaves, that's when you need to call the guys and probably buy some new canisters. So before they break down, so you can kind of see what's going on there over time. All right, let's see how we're doing. All right, we're making headway. All right, so that was kind of a review of just some stuff to remember, remind yourself about, important stuff. Let's get into cases here, and then I'll try to get to some common stuff that comes up as far as questions, and then we'll answer all your questions here, hopefully in the last 15 minutes. So biggest thing, make sure you're picking the right cases. Again, some people will say I use the sew-in and sleeper one for every last patient. We don't. I don't use it like that at our office because I'm a program director at residency. So like, I have the residents still block. I have them do everything because I need to know how to do it. I'm sure some of you in your offices that you have full control over and you're by yourself for the most part, you could probably use one of these devices on most all your patients in most all situations and be completely fine. So some of us are all in. I'm not fully all in just because of where I teach and where I work. But yeah, if I really wanted to use it all the time, I probably could. Make sure you have a radiograph. Make sure you have a really, really, really good radiograph showing the bone. You have to. I'll show you a case or two here where that didn't happen and what happens when that doesn't, when you don't have those things. Active infections, again, same rules. Stay out of active infections. Don't inject into infections. Radiolucent areas, again, you're just going to see, the tissue well up. You're going to see all the local go into that void. It's actually not going to go in the bone, and then your kid's not going to be numb. So you do need radiodense areas to put that in. We'll talk about some cases. Well, what if I have a buccal fistula? You can go from the palate. It's totally fine. It's not typically what we do every day, but it's an option. You need to know how to do that and think outside the box. All right. So anterior teeth, again, your stage 1, get that little area numb. Might penetrate over to the palate too. You might get that. You want to have a nice x-ray. If you look down here, so you see that intermaxillary suture, excuse me. If you get so lucky/unlucky that you get perfectly into that suture, you're not actually in bone. You're actually in like dense tissue. So sometimes that will actually have all the local go up into the vestibule, and you'll see this kid's vestibule start to basically well up like you're doing a traditional infiltrate. So again, always watch the surrounding area when you're administering local. I'll show you a picture or two of what I mean if you don't understand me. So, if you go perfect midline with this between E and F, you might get that. That's why I say just a millimeter off either way if I could. So you got your stage 1, then your stage 2. Again, ideally you're trying to get canine to canine. Again, it's dependent on local you're using, volume you're using, and then the epinephrine concentration you're using too. And most of the time these palates get pretty numb too. So that's what you're aiming for. Again, if you get so fortunate, lucky, unlucky to get right in that intermaxillary suture, you probably won't feel that resistance, and then you'll actually see some changes in the vestibule because you're actually kind of all that local is deflecting up into the vestibule. So just make sure you're actually in bone. This is what I mean by that. So this is a situation. Now, trust me, these X-rays in this kid don't line up. But if you got perfectly into that suture, this is what's going to happen sometimes. You will get some of that vestibule kind of fill up with local. So you're not actually in bone. So at this point, I should come out, I should redirect and actually get back into bone because otherwise, this person's going to have 8 and 9 pretty numb, but that's about it. So if you start to work on 7 and 10, they're not going to be very happy with you. So, boy, sorry about the cough, everybody. So just be aware of that. Again, always check your x-rays, be aware of what you're working with and what's in that ballpark. So this is a tough one. I took care of this case. We still did this. Again, this might be something, you know what? I don't have any bone to work with. So we're going to refer, we're working on tooth number 19. So distal to 19, we have 18, we have no bone. Mesial to 19, we have a little bit of bone maybe, not a whole lot. Could I go in the furcation of 19? Yes, that's a possibility, but that's up to you. That's your discretion. That's your comfort level. This might be one of those situations where it's just this like perfect, unfortunate timing where everything's erupting. They might have to go old school and give them a block. So again, there are times and places when you do have to, revert back to other things, but again, it's not a lot. So, let's talk about placement of the device, where I put my hands, how I approach things, stuff like that. This seems to be something that some people have some challenges with, I feel like. Again, we talked about isolation devices in there, evacuation or a 2x2. So always have that in there because otherwise that kid tastes that local. It's bitter, it's nasty. So upper rights, I'm right-handed. So I usually sit at this point, I'm sitting probably like 7 o'clock. I do my stage 1 like this. So I'm almost coming up like aiming towards their eyeball. So some of you guys will come in like you're going back towards, tooth number 2 or 3 at that angle, almost like parallel to the occlusal surface, but I almost go, perpendicular to it. So stage 1, stage 2, again, if you don't have any buccal bone, you can do the palate. So again, stage 1, you're almost going parallel to that palate and then just redirect ever so slightly. And then just advance, and then you can do your IO that way. So again, on the left's the routine, on the right is the kind of audible. Whoops. All right, so that's the upper right. Then we're moving towards the front. Same thing. Just make sure you're, back in space enough. If you have a kid that's like, really got some flared out incisors, you're gonna have to really go back in space when you deliver the local. Make sure you're in bone. So, and always just watch to make sure you're not in that septum, that suture. Same thing over here for the left side, stage 1, stage 2, and then palatal. You can do the same thing. So, again, for the most part, I'm almost sitting at like 6. I'm sitting like 7, 8 o'clock with most of the patients when I treat them. So. I'm going to show you one little thing I do different here. So sometimes what I'll do, so you can kind of see here the second window in, I'm there kind of at 7 o'clock. I'm going to the bone. So once I'm in, I kind of shift my body back to 11 o'clock, and then I'll trade hands. So I'm right-handed. So now my right hand comes out and holds the lip down, and my left hand will actually support the device. So it's much easier. It's much more comfortable, and I can just sit there, and I have much better head control for this kid, so I can hold the kid a lot better too. And then at some point when I'm done, I can actually just take it out left-handed. So I don't need that much dexterity to do that. So just kind of twist it and pop it out. So you don't always have to sit there in an awkward or an odd position holding it right-handed. You can just kind of reset and just hold it left-handed or whatever your non-dominant hand is. So, and then same thing over here. You can go on the palatal side. So, all right, let's see. 8:45, I got to about 9:10. So we got about a half hour. So again, sorry if I'm talking fast, but I got a lot to cover. So hopefully we'll get to the last 20 minutes here and we'll have lots to answer. So, all right, a whole bunch of cases. So you can kind of see here, my whole goal, I got basically 8 kind of subsets of folders here. So we're going to kind of at least hit on 1 or 2 of all these. Hopefully it will answer a lot of your questions. And then we'll get to the last piece, which will kind of fill in the gaps, hopefully. So Anteriors again. So do that mental checklist. Do I have bone? Yes. Do I have a intermaxillary suture? Not really. So I'm good there. I have plenty of room to the right or left that midline, so I'll probably aim for that. This kiddo just, he's a sedation, needs these two front teeth crowned. I think he had two posterior teeth too as well. So again, um, not a big deal. Got to check that bite, right? We got a nice deep bite there. So again, Dawn zirconias is probably your best bet. Dawn strip crowns probably won't last too long. Anything white facing crowns, signature crowns, probably not going to last too long. So again, get in there, find your crowns. If you're between a 2 and a 3, I always by default go to the smaller crown because they're going to look a little better. So we decided we're going to use the 2s. So get in there. So this is kind of stage 1. So just gentle press. Again, this kid's sedated, so that's why he was, good. We don't do any IV sedation; it's all oral sedation. Um, but you see a little leak in there, so I probably just need to penetrate a little further. Again, what did I not do? I didn't put that 2x2 in there, so I probably should have that there, just to grab a little bit of that's leaking. And then, I'm just trying to stay off the midline just a little bit, so I don't get stuck in that intermaxillary suture. And then slowly just kind of twist and advance, twist and advance. At some point, I'll either have no resistance, kind of like there, right there, dropped in. So I'm just going to sit there. So just keep the lip out of the way, hold the device. Again, I got my eyes looking at the needle. I got my eyes looking at the carpial just to make sure that's moving. And I have my eyes on the lights just to make sure they're moving. And then I got my eyes back on the kid. So just kind of going up and down. When this is all said and done, use about a half carb. No need to do a palatal injection. This did it all. This took care of both those teeth. So just sit there, and then we're at 2, we're at 1. So again, that's a good place to live at. And that plunger there, you can kind of see it slowly moving down. We'll talk towards the end here about how do you know where a quarter carp is and how do you know where a half carp is? I'll talk to you about that, and I'll give you my kind of 2 cents on that, just an easy way to remember that. Again, you don't have to sit there and wait. You can just, by the time you get done, remove the device. You got your crown sizes fitted, and then go to town, start prepping. So these guys didn't need pulps, so that was great. And then just a little tidbit I like to use. You get these teeth that have just that annoying 1 millimeter kind of space between them. Can't get floss in there, so I always take my 2x2 and just double it over. It's really thick, almost like super floss. I just kind of slide that in there and clean up between those teeth. So that always works nice. So again, real quick, real predictable. Kid's not numbing his palate. His lips probably minimally, if not at all, numb. So much better for the kid. Again, same little situation here. Watch the angulation. I probably angled this a little too much. And so either A, I angled it a little too much, or I ended up getting right in that intermaxillary suture. And that's why you can see that vestibule right around the front of there starting to kind of well up with a little bit of local. So at this point, I want to come out, probably redirect, and then just find a different angle or a different place, 1 millimeter to the right or left of where I injected at to stay out of that. So some posterior teeth here, primaries. Again, kids coming in, A and B and S and T all need some attention. Do I have a good bite wing? Yeah, I have a great bite wing. So I got some bone. I know where I'm going. I love vertical bite wings. I don't know if you guys take these or use these, but these vertical bite wings, instead of going to the OR and taking 4 PAs or 8 PAs, just if you take 2 really good vertical bite wings, they're basically everything you could ask for. They're bite wings, and then they're PAs all in one. So these are great. So you don't really need to, irradiate the kid and save yourself some time in the OR or just in general. So those are my 2 spots I'm shooting for, those X's. So this is the same kid. So again, you guys have all done this. So I know you guys know how to do this. But again, just kind of pressing in there. Let that blanch ever so slightly. Some of these videos I let blanch a little too long because I did these probably about a year or 2 ago when we were just starting to use this thing. So at this point I would stop right there. That's blanched enough for me. Again, I prolonged this another 5 or 10 seconds more than I should have. I'll show you how I swing around here. I really prolong this thing. So yeah. So just get the lip out of the way and then So move forward, hits the bone, and then just move forward. So I could just go forward a little bit. I knew I hit bone, and at that point, I was good. And then that thing just slid right in. I didn't have to twist it, didn't have to manipulate it, didn't have to do anything. So we're good there. Same thing upstairs. Again, I kind of come in this way, almost like vertical, like almost following the long axis of the tooth. So that's how I do mine for upstairs. And then all I have to do is basically come out ever so slightly to do the stage two and then redirect like 15 degrees or so. So again, I got the isolate in there. I could have had a 2x2 around there too, but really not much leaking here. Again, that's enough blanching at this point. Again, I made this video a while ago, so I probably would have stopped at this point and redirected. But when you're starting to learn how to use this, you sometimes do things, maybe not as the same way you would do them later. So just redirect, advance forward, hit the bone, and then just kind of feel for it and kind of see I'm pushing there. It's bending a little bit, and give it a little bit of a little more pressure, a little bit of a twist, and it starts to go in. So sometimes, again, this kid's younger, so you might not feel that drop in, but again, at this point, I can tug back on it, and you're not going to feel any movement. So you're in bone. So just keep an eye on all the surrounding areas. Make sure you're not having it in the PDL where it's leaking out the sulcus. All right, extractions. Remember we talked about too. We obviously F needs to go for a ride. He's had enough. He's done. But we need a good X-ray of this, and you can imagine as well as I, there's probably going to be minimal to no bone around tooth F. So where do we go? But remember we talked about we can get typical anesthesia from C to H. Now, you might have to go from the palate for this if you have no buccal bone at all. I'll show you what we did. So here's our X-ray. There is literally nothing. That tooth F is just floating there. So we decided we're going to try to find that little parking space right here adjacent to E, and we went in there. Again, you don't want to go on the infection. If you really had a kid that was, not happy, he was fine. You could go distal to, G there as well. You might have to do it twice, but this kid ended up being fine, and just kind of stayed in that area, and then helped out F, and then all that infection, all that stuff drained right out. So, all right, this is why we need X-rays. If you look at this patient on the bottom right, you got ST and 30. Everything lines up pretty nice, looks good. You look on the right, look at the picture on the far right. You have KL and 19. What's going on between K and 19? There's some space. That's odd. That shouldn't be. Well, this kid didn't need any work done on K and L, but fortunately he had a pan before we saw him. So we gave it away. There's our pan. And there's where number 20 is hanging out. So, hypothetically, if K needed something done to it, a pulp and a crown, a DO, something like that, you'd want a better picture of what we had when we started. So the issue is now we need to get K out of there. And the last place you can go is obviously distal to K to get this kid numb, because you're going to end up hitting number 20. So we have to go here measly. So again, start about 15 degrees, get in there, do your stage one, and then kind of swing around. Sometimes I don't go as high as we're always told, like kind of almost come from the occlusal down towards the apical. Sometimes I go from the side because that's where I can get bone or access. And you can kind of see here, we're holding this left-handed. So once I'm in, I'm just holding this left-handed, supporting this for, the 45 seconds or so that it takes to get that third of a carp or whatever we're going to put in there. So that point, we're good. Get our cow horns in there. Really aren't supposed to use cow horns for primary teeth, but this is a different situation because our tooth below it is not really there. So that thing popped out, no questions asked, no problems from this kid, just by one simple little injection right there. But again, the point of this is make sure you have an X-ray before you start, because otherwise we would have been banging into tooth number 20. So what do you notice here? This is immediately post extraction. There's minimal to no bleeding. So again, that's a great thing. So it's not just for these teeth. Yeah, this is great. Sometimes these kids don't bite. They don't cooperate. It's blood everywhere. They're swallowing blood. It looks like an exorcism. It's bad. So, but again, with this, there's minimal blood, no sutures, no nothing. So the really nice part is when you get to anterior teeth and extract those, there's minimal bleeding. Hence my segue. So little kiddo here. This kid's another case, 26 months old. Um, Trust me, I would have saved these if I could have. The problem is the kid's got an anterior crossbite too, amongst other issues. So these ended up being extractions. So otherwise, you're going to end up injecting this kid probably 2 or 3 times. You know, the vestibule between D and E, vestibule between F and G, palatal. None of that's fun. None of that's comfortable. So same thing here. All you have to do is your stage one, and then your stage two. At this point, we got lots of bone, really no intermaxillary suture to work with. Probably just a little over half carp there. And then that's why we couldn't save these teeth because they were already in a crossbite. And then you can kind of see, look at the palatal. This is not Photoshop, trust me. It's, the left to the right. So that palate is all numb. So no need to do a palatal injection, which are never fun. And then take these out, literally give them a squeeze, 60 seconds later, minimal to no bleeding. So again, this kid is not going to bite on a piece of cotton for you or anything like that. When they walk out the door, they're going to be screaming, crying, spitting blood everywhere. It's on everyone's shirt and it's a mess. And he's not a happy camper, but at this point, he's much happier and there's minimal to no bleeding. So it looks a lot better. It's under control. And it's just because that local got put into the bone, I feel. And then epinephrine then allows for all that vasoconstriction to happen right there. Same thing here. Got an extra tooth. We got D, E, F, G, and then G super. We get a little infection there too above F. It's the same thing. Lots of bone to work with. And then a nice evil side eye from this kid. No nitrous. The kid whines and cries a little bit, but overall, it's, all you have to do is keep these kids stable. That's the only tricky part with this. You just got to keep them stable while you're administering it. So it will take a little longer versus traditional, administration of local with a syringe. But the nice part is you have to get in there once and just stabilize them and stay in there for one spot, one injection, not 2 or 3 sticks. So, which is nice. Again, same thing, immediate post-op. Again, gave it a squeeze after about 60 seconds, took a picture, and there's minimal to no bleeding there, which is great. So, we're not going to hear crying kids. All right, I got 10 more minutes here. So, anterior teeth. This is probably the most painful, difficult, uncomfortable, in my opinion, local to give when you're doing this traditionally with a syringe in the upper anteriors, because if you go a little too far, I feel like you're in their nose, you're going to hit bone. It's uncomfortable. So again, this has been a lifesaver, the sew-in and these things for like these front teeth. They're so much easier to work with. So one of the residents I timed her, I said, all right, well, let's go. So there was a nice, I'll show you the x-ray in a minute there, but just straightforward MFL on number 10, medium size, wasn't small, but wasn't gigantic, but it was pretty straightforward. So I said, all right, you go. I'm going to take pictures and then I can check my timestamps on my pictures and I'll figure out exactly how long it took you. So 8:35, this kid sat in our chair. 8:40, we got about a third of a carp of septo administered. By 8:48, she had the prep completely done, to her liking. I was able to come over and check it, this, that, everything else. So again, there's some downtime. Again, we're dealing with a resident here. And again, you can look at the x-ray. That's not a small carious lesion. And then by 8:54, she had the thing restored, polished, and the kid was out the door by 9. So it's pretty good. She took the hard way here. She actually went between 9 and 10. If you look at the x-ray between 9 and 10, that's like the most difficult thing you could have done. So don't force yourself going between 9 and 10. There's no bone there. Somehow she got in there just right. If I was her and I would have redirected her or just re-guided her, I would have said, okay, I need you to go between 8 or 9 and you still get 10 numb, or you go between 10 and 11, you still get 10 numb. But she chose the hard way and it worked out, but just, this is why you need a good x-ray to make a decision where you want to numb. And you're going to get frustrated because you're going to try to get this kid numb between 9 and 10. You're going to hit the tooth or you're not going to get in bone. So just go for the easier one where there's more bone. So there's your there's your post-op, all fixed up. So same kind of thing here. Again, lovely post-ortho, forgot to brush my teeth, lots of halos, lots of interproximal areas. A lot more area to work with here. Again, we could go now. Again, we're dealing with tooth 7 and 8 here. So again, I wouldn't necessarily encourage anybody to go between 6 and 7 to start. My goal would be go between 7 and 8 because the chance of you, getting both of those profoundly numb with a reasonable amount of local is probably the best. So we use 1 to 200. You could have used 1 to 100 because we're just using those two teeth in the front. So Septicane doesn't matter. You could use lidocaine if you wanted to, honestly. So it's your discretion. So that's our goal. We're trying to shoot for that. Again, stage 1, make it a little blanched, and then redirect your device just a little bit so it goes further back in space, almost kind of aiming towards their like uvula. Maybe not that far, but maybe like back towards the back of their head. Get those prepped out. Again, minimal bleeding. Get that one little bit of bleeding from your spot where you injected at. That was it. And then afterwards, you're all cleaned up. So, but again, just one spot you got to inject, not 3 or 4 spots up in the vestibule. Just uncomfortable. It's just that's a miserable injection to give, and it's a miserable injection to receive. So, all right, we're winding down here. So, again, pretty easy right here. You have lots of bone, lots of space to work with. We use lidocaine for this. Why? I don't know. It doesn't matter. It works. So this is the very first video I showed you when we started this whole thing. So, but anyway, that's our prep. That's what the prep looks like. And, it was done lickety split. I don't have the exact timing for you, but again, there's no downtime or minimal downtime between the time you inject till the time you prep. So somebody posted today about von Willebrands on the user group. So I said, well, I'll just keep this in here. So one of the first patients I actually had a hemophilia. So if you had hemophilia patients in your office, these kids go through more stuff than you probably care to imagine. So constant injections, constant everything at the hematologist. So, and then blocking these kids is really a no-no because you are blocking back into space through a muscle that if you do cause any kind of bleed, you really have no way to stop it. So again, this is the absolute best situation for anybody who has hemophilia, probably a good situation for anybody with von Willebrands because you're going to just go right next to the tooth. And the chance of if you block somebody, the chance of you having an airway obstruction or an issue, it could happen from a hematoma. But with this, you're not going to have that situation. So again, radiographically, this doesn't look that big, but trust me, when you see this thing, it was actually pretty big. So once we got this thing opened up, and I asked this kid afterwards, and again, this kid is a little older too. So everyone talks about what's the limits for, can I do it on a kid that's 16 or 17? Like, yeah, you can do it. It's really just bone density, angulation, a little bit of luck. But yeah, if you get in the right spot there, you're usually pretty good. So, but just advance till you feel some resistance and then just give it a little wiggle jiggle and you'll pop right in. So sometimes it's a little slower. You don't get that pop and release. Sometimes you just have to work it in there. But this is a fairly deep lesion when it all got said and done. So, and I asked the kid afterwards, I said, how was that? He goes, that was totally fine. Like, it's so much better because he's so used to having, unfortunately, all these, injections and infusions done all the time that this is a joke to him. But either way, it's frustrating for us to work with a kid that has hemophilia because you probably traditionally would throw a carpal septo or two at them to get them numb, and then you hope they're numb, but that's not always a guarantee. But again, I'm going to probably skip over this one. This one's a tricky one. This one, not a lot of bone to work with, right? So there's not much mesial to 19. There's not much distal to 19. So again, this is a really outside the box one I did. This is like old school, like an X-tip, like endo. So I actually went to the furcation of this tooth. Did stage 1 right where I thought the furcation was, and then aimed for the furcation. And just slowly advanced. And then I felt a little pop in. Once I felt that pop, I stopped. I didn't want to obviously penetrate and hit the root, but sorry about the sound there. But I didn't want to hit the root, but I got just enough through the bone that I deposited the local into that furcation area and got this kid numb. So again, could you have to revert back to an old school block? Sure. If you have to, if you want to, if you're not comfortable doing this, but this worked in this situation. So cleaned it out best we could. Trust me, that's clean on the bottom. It's the lovely reflection from my phone taking pictures, but some neo putty, some liner, restored that thing up nice, and then took a post-op. So, all right. Permanent extractions, you guys can do these if you want. I'm going to kind of scoot through so I can get to the end here. Premolar extractions, we do a fair amount of these just because of where I work. For ortho, not all of our kids can get phase one and get expansion. So sometimes I'm taking more premolars out than I would care to take out, but that's the nature of the beast. So again, same thing with this, just like with the primary extractions. I find sometimes when you extract these premolars, you get a little bit of a rush of blood as soon as you get the extraction done. But as soon as you get control of that, the bleeding stops. So these will bleed just a little more, I find, right after you extract them versus a primary tooth. But for the most part, there's minimal bleeding. So again, just typical videos of stuff you guys probably do all the time. So, but I'm gonna get past this and I'll get to the last couple of questions here. Then we're gonna turn over to questions for you guys. So, but again, you can kind of see those sockets look great, minimal bleeding. Again, they fill with blood. They're going to heal back up, but they're not profusely bleeding. So, and again, you want to take all four out in one visit, no problem, right? So you got a patient that drives an hour. If somebody drives an hour and a half, I can use two carps, half carpa septo in each quad, and bang, 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 that kid's numb, and those things are out before you know it. So it's great. Non-restorable teeth, same kind of thing. Again, you can see we use lidocaine here, didn't have to use septicaine. So just trying to prove a point that you don't have to use septo. You can use lidocaine. So, all right. I'm going to scoot through this because I don't know how many of you guys actually do this, but these are mesodents. So same thing, stage one on the left, stage two on the right. Make sure you go back in space enough. Get all that numb. And then you can kind of see this is our before, and this is our... Bear with me. Cut here. But see how blanched that is where I just circled that? That's again just from just from that initial injection. We use lidocaine again. We didn't use septicaine. Lidocaine, I think, is going to buy me a little more time for post-op for discomfort or pain for this kid. And then get in there and use a Denhart mouth prop if you want with these. It'll keep it out of your midline. But it's just a half carpal lidocaine. So get in there, access that, remove a little bone, get the tooth out, get the follicle out, suture the kid back up, call it a day. And that's 3 weeks later. It's all healed up. So, all right. I'm going to scoot through these because I want to get to the last couple things. That's a lovely mesodent. Look at that thing. It's like a 45-degree bend on that thing. Hypomineralized teeth, again, same exact thing. These teeth are usually angry, agitated, not happy teeth. So again, a lot more predictable getting these numb. Got to have the bone for the placement so you can get your local in there. So again, sorry I'm skipping over these, but again, it's more of a function of I got to get to the last piece here. We'll do a lot of band stabilized buildups for these guys. So if God forbid that direct pulp cap we did there, whatever we did needs to go to endo, they have easy access to get through that tooth, and they have support, and then put a stainless steel crown on it they have to go through, and then we have to replace again. So again, this is all day, every day. And then every once in a while you get a premolar that acts up too. Same kind of thing. Clean it out, restore it, and usually pretty good. Again, we got both those teeth done with just a little bit of local. All right, I'll keep this up for a second. So if you guys want to take a picture with this with your phone, probably not a bad idea. That's the user group. If you're not on it, get on it. If you're on it, you're cool. If you're not on it, get on it. So lots of good questions. Erin's great with that. Erin's like she's the queen with that. So she always throws videos up. If there's questions, she'll kind of troubleshoot something for all of us, which is great. So these guys are always really accessible, which you guys all probably know. All right, let me buzz through the questions that typically come up in this user group. Then I'm going to turn over to you guys. So Why is the local still coming out of the syringe when I'm not pressing a pedal? We talked about this really briefly. You got to remember that that plunger's under pressure. So when you remove that from the bone, it has a little bit of back pressure. So you might get a drop or two come out. So what I do typically is I take my foot off the pedal, I'll gently back out the device, and then hopefully that little bit of back pressure releases, um, and then just come out of the mouth. Or if I come out, you might get a drip or two just because of the back pressure. So you're not doing anything wrong per se. It's just that's the nature of the beast. How do the pedal and the sewing communicate? There's no battery. You don't have to worry about changing a battery, nothing like that. So if it's not communicating, it's not like the battery in the foot pedal's not there. It's not there. It's not. You need to change that because there is no battery there. You just need to move those together closer so they can communicate. Or, like I said, if you have multiple of these in your office, make sure those two are married. And Jordan and Aaron can go over that, but just usually a serial number that you can match up pretty easily. We talked about the pops. Sometimes you feel it, sometimes you don't. If you don't, kid's probably younger, bone's probably softer. Again, do the little tug back, and you're usually fine. Um, I got some local that's not flowing, and the third or fourth light's illuminated. Well, that means you're stuck against a wall, probably. You are stuck either against a tooth, you're stuck against a bony, trabeculae, something like that, or you have a little piece of bone that actually got stuck in the lumen of the needle. So again, do not take your foot off the pedal. You do that, it's going to reset the whole algorithm. So just keep your foot on and just back out the device a little bit. Check your lights again. If the lights go back to 1 and 2, you're flowing again. If the lights do not, probably stop, take everything out, and you might have to change the needle. You can either A, redirect it first. If it works, great. If it doesn't work, you may have something stuck in that lumen of the needle. It does happen, but not a lot. So, two or three more things here that I'm going to wrap up and turn over to you guys. This comes up a lot question wise. So, am I in cruise? Am I on drive? So cruise basically tap the pedal, let go, it goes. Tap the pedal, then stops. Drive is basically, unless your foot's in the gas, it's not working. So this is just a quick rundown to go over this. Aaron put a video up so you can watch the video. Here it is basically in just pictures. So if you're trying to change from cruise to drive. So again, I find a lot of times it happens. The assistant will go to reset the plunger, hold something too long, and they'll see lights come up and they'll start hitting it again, and then it'll change some some settings. It's much harder to change this though because you actually have to hit the pedal. What's not hard to change though is the next one, which is some of you guys brought this up, which is this part. So what if I'm hitting the pedal and it goes to a quarter carp and stops, but my foot's still in the pedal? So what happened is most likely things changed in there. Someone was, resetting the plunger, held it down too long. It opened up into a menu, and then they started hitting buttons, and then ended up changing the settings from a full carp you could give to a quarter carp. So you have to understand how to get through these. So again, there's a good video in the user group. Again, this is how it is. Basically, if you want to just take screenshots of this or rewatch this, but as long as you know how to use this menu. So again, it bears refreshing to go back through this. So two more points, then I'm done. How do I know how much I'm giving? Here's my best suggestion for you. For the local that we have, I use this as my rough gauge. So we're going to say 0 is where the plunger had to start. Yeah, you're going to lose a couple drops for your stage 1. Once that plunger gets a little past that silver band, that gold band, that red band, you're at a quarter carp. Once you get that plunger just shy of the expiration date, you're at a half carp. Once you get that plunger past the expiration date, you're about 3/4 of a carp. And then obviously you guys have used this long enough. There's a needle that penetrates through the diaphragm of the local. Once that stopper hits that, it resets. So you never can give a full carp per se. There's always a little dead space at the end. So we talked about limitations where the local can go. Obviously, if you're trying to work up on a lip or try to do a frenectomy, you got to do something directly into the area. You can't do anything around it, and hopefully it penetrates there. We talked about using palatal access if you don't have buccal access. And then obviously moving the units together closer. All right, last one. So sometimes you will get some post-op discomfort. Oh, also too, if you're in there and you're on your last, you're actually in the bone still, and it resets where it starts to come back. The plunger resets, and you might get some blood in there, right? Because you're actually still in bone, which is full of blood. So you might get some red in the carpial. So it does happen, but again, it's nothing to be worried about. Lastly, pain, discomfort, post-op stuff. Post-op, I don't think we've nailed down the exact why. Theoretically, it's either probably a little too much local that was stage one local that caused some irritation or some necrosis in that area. So you might get some discomfort like this. Patrick Ruck in Cincinnati, he had this picture here. Again, this is soon after. So did the kid pick it? Was a little necrotic from like too much local in that area. It healed up really well, but this can happen. If you are not in bone and you're like perfectly between the gingival tissue and the bone, and you're actually putting in between those two, you're going to actually separate those tissues and you will get some necrosis and some discomfort there. So again, ensure that you're in bone when you're doing this. So you might have some soreness there. You might have some, discomfort. Again, is it from the dental procedure? Probably a little bit. Is it from the device usage? Possibly. So just be prepared for a call like this. It may happen, but just a heads up. And that is it. So how did I do on time? I did okay. At any rate, you guys have used this. Hoping you guys are finding success with it. The needles are a huge part of this. You should not be using as much locally as you guys have historically. You should have a lot better predictable nature getting teeth numb that in the past may have been a headache for you all. What else? Again, the other thing you have to kind of change is your workflow. You guys have probably figured this out at this point. Once you get the kid numb, you can start working right away. So the first time I did it was the weirdest thing. I'm like, I'm going to pick up my handpiece now and start drilling. I'm like, okay. So you have to change your workflow a little bit. Soft tissue anesthesia and soft tissue issues afterwards should not be something you're experiencing, if at all, if minimal. And be patient. There's going to be some learning curve with this and some frustrations. I mean, have good x-rays. You'll have some kids that are a little sore here and there. These things happen. Nothing we do is perfect, but just be aware. So this is all the new stuff coming up. So if you want to come to Chicago next weekend, I'll see you there. No, but there's a bunch of hands-on. So Midwest, Southeast in Charleston, West Coast in LA, Newburgh up in Oregon, Fort Lauderdale if you need some sun, or if you want to see Boston in the winter, I'll be there too. So lots of stuff coming up. These are your people to call, bug, harass. If you have any questions, and that's about it. So, all right, Jordan, Aaron, I'm going to turn it back to you. I don't know what questions there are, but I have as much time as we need to go through them all. So just let it rip.
Awesome. Great job, Paul. I appreciate all of that.
Sure.
So a couple of questions here. Dr. Katie Gom. So this one's a little bit longer, so I'm gonna read it off to you. So I've just started using the SOAN the past 2 weeks, and I've been bending so many needles for all age groups. I'm really struggling, not often feeling the pop through the cortical plate. I feel like I'm doing everything correct, grip as close to the needle hub as possible, finger rest, pressure. However, I must be doing something wrong with my angulation. I'm trying to visualize where the roots are, etc. Any tips you can give me would be much appreciated.
That's such a tough one because it's like, here, let me show you this. Watch me do this. That's a tough one to walk you through. It sounds like you're trying to troubleshoot it. Sounds like you're trying to work it out. So be patient. So I think do your stage one, that's easy. Do your stage two, make sure you're angled. Sometimes you angle too high like this. So sometimes angle a little more parallel, not as vertical. So start like that. See if you can get a little more success coming a little more parallel. But again, just advance till you hit bone. And then when you hit bone, it's not a quick twist. It's a slow, focused twist. So sometimes you'll pop in, sometimes you just, you'll go and twist and go. So be patient with that. First time I did it, bent the needle, snapped it right off. So been there, done that. It happens. But But that's where you just have to learn. It's that balance between how much pressure do I put, how much twist do I put, and you know what, this is not working. Let me re-angle it. And if you do it 2 or 3 times in the bone, you're going to start to dull that needle, and then you're going to get upset and irritated, and it's not going to work for you. So um, try the chicken bones if you want. That's probably a good thing if you want to do something like that. Um, Go to the OR if you have the ability to go to the OR and take that to the OR and try it there. These are kind of solutions, but again, if you don't have access to that stuff, it's a tough one. I'm not sure where you're at. You can talk to Jordan or Aaron, and if there's a KOL that's, for whatever reason, crazy like in your ballpark, you might be able to go see them and they can show you how to do this stuff. But reach out if we can help you. So it's hard to coach you like this. It's almost like I got to have your hand. It's almost like literally a hands-on kind of help. But
Um, Good point with being able to see somebody. So she's actually in the Denver area. So I'm going to volunteer Dr. Matt Lucero. He's on this call. He crashed out and got back onto the call. So Matt, glad you're back on. Dr. Katie Gom, I might connect you to and see if you might be able to assist
yeah,
in any way.
Matt's a good guy. He'll take care of you. What
And
else?
then the next one, again, from Dr. Gom. For really loose teeth on a super anxious kiddo, would you just use the Soan F-Tech needle with the PDL type of injection to make it as pain-free as possible? Or do you need to be aware of where the D is positioned for this?
With that, if it's super anxious kid, me personally, probably use some topical, use as much topical as you can get in there. And then I might go old school, use an old school syringe and just do an infiltrate with that. That really depends because with the scenario you're painting of an over retained tooth, you don't have a lot of bone to work with. So you might just want to do an infiltrate in the vestibule somewhere. Yeah, you can use the Epitech needle. That's going to slide in a lot easier and probably be a much smoother insertion. And then just don't do an IO. Just do it in the vestibule, and then that should work. So just like you were taught probably to do. But yeah, you can use the device still. You can use the same needle. Don't try to. Those things they're not going to come out when they're just floating in there. You have no bone, so it's probably not worth it. You can try it, but I would just be careful with that.
Awesome. Um, and I know Aaron will talk about this all the time as well. You can use the Soan in a traditional sense, use it to infiltrate.
Mhm.
So you're absolutely able to do that as well. Any other questions? Please put them in the Q&A. Looks like that's all the questions for right now.
Okay.
Please put them in the Q&A. I'll give us a couple minutes.
And there's this 16 millimeter needle too, if you need something longer. So we always talk about the 9 millimeter needles, which are fine. They're great. There's a 16 millimeter needle if you want to use that for those infiltrates. And then there's a 35 millimeter, harpoon thing that you probably don't need. But so what else do we have?
Um,
Anything else?
Another question, Dr. Braswell, where exactly are you placing a 2x2 when soaking up the local that drips out?
Got it. Okay.
And yeah, feel free to go back to any side or slide and
I'll just do this guy.
you
All right. Woo, hope you can see this. So listen, if I'm downstairs like this, I'm gonna just put the 2x2 around, basically around the tooth. So it's probably not a great way to show you there, but yes, I keep typing onto my desk. I'm weird. So there, I said it. Um, let me see if I can help you out here. All right, let's play the game here. So do this. Basically, imagine that isolate's not there, and then just imagine that's the 2x2. Just wrap the 2x2 from that, where you give your long buckle there on 19, basically around the whole lingual side there. That's all you need to do. So you can do like a horseshoe or like a J almost. So I just like kind of put it in there and then use that as my kind of just sponge. So hope that helps. But like basically just wrap it around the tooth you're trying to work with. If you're working with something upstairs, I just put it below it because obviously gravity is going to pull it down. But that's just another way to do that, to have a 2x2 there. So
Aaron, you want to take this next question?
Sure. From Dr. Nasil. I know the answer to this one, but can you use the needle tips on any syringe or does it only fit the Soan?
Well, you want to answer it?
I don't. They only fit the sew-in. They're one step ahead of you, and Dental High Tech thought of that, and they only fit the sew-in. And reverse is that your traditional needles will not fit on the sew-in, so you need to use the Epitech ones.
Yeah.
And they're worth it. They're about 27 cents a needle, which is not too far off from a traditional needle. So it's not like we're not charging $1 a needle or anything.
So yeah, I mean, it's worth it. Yeah, it's literally a couple pennies, and like I said, you might use two in a patient instead of one like you used to. But again, just don't get so cheap that you're trying to save a needle because you're gonna get frustrated and it's not gonna work like it should because that's gonna dull after you bang into some bone 2 or 3 times. So just don't be stingy. Just change that needle out. What else you got?
Dr. Wu just posted, hi, I often have issues at step 1, where I step on the middle pedal and nothing is happening. No lights are blinking. I am very careful that it is just the middle pedal.
Mm-hmm. Best solution, I mean, I would, start, just make sure they're communicating, make sure they're talking, make sure they're not too far apart. So like what I do before I even get this even near the patient, I load everything, I hit the pedal over to the side, and then just make sure the lights are blinking. So just make sure they're talking. And then, like I said, if they're talking, you should be good. You're not going to get a lot of local out of that. You're going to get the smallest little bit. You might be getting the local to come out, but it might actually be so superficial that it's one little drop that's coming out, and it's actually in the mouth, and you're not actually in the tissue. So just make sure you advance it enough, and you should see it blanch. Those videos I showed, I took way too long to watch the blanch. They were way over blanched. I should have gotten done sooner with those. But that's your best solution, I think, with that. Is just make sure they're talking, and then after that, make sure you are in tissue, and then you're not going to get a lot of volume out of there. You don't want that volume. You just want a little bit of volume, and then once it blanches, you should be good.
I would say on that too, just make sure you see those lights blinking. And I know a lot of doctors have had trouble if the pedal is underneath the patient's chair. It can cause interference between it talking to the handpiece. So just kind of move it out to the side a little bit and see if that helps. And Dr. Wu, if you continue having issues, definitely reach out to us, and Jordan and I can troubleshoot with you and make sure there's nothing wrong with your device. But try those things first. And Dr. Wu again, how do you determine how much anesthesia to give? Half a carb, a third? Is it dependent on how many teeth, dependent on age, bone density, extraction versus filling?
Yeah, there's no magic algorithm. I think it really just boils down to what are you trying to accomplish? Are you trying to accomplish 3 teeth in a quad? So I would use 1 to 200 because I'm trying to, diffuse out that local to a wider area. So that's what I'm trying to accomplish there. So I would use 1 to 200 septo. How fast do I work? Am I kind of slow still? Do I have a lot of work to do here? I might have to re-inject the person because again, I might be doing way too much work over a span of a whole quad. So like that depends too, because again, the local is going to wear off at some point. So again, do you want to use Lido? Because hey, I need a little more time to buy, so I need that in there a little longer. So lidocaine might be a bet. That's an option there. Are you just working on 1 tooth and you're just doing an extraction of number 20? Well, then I'd use 1 to 200 septo. That is right there. I don't need that diffusion. So, and then again, the volume. I wish there was a magic, formula you can come up with. But if you're looking at a really young kid, you're in a sedation, something like that, you're like stingy with your local, you got to take it easy. But if you're working on a teenager and you're trying to get a quad done, you could use, half, 3/4 of a carb if you want. Depends on what you're trying to do. So the bone density, I don't think is an issue. I think it's more timing, how much time. Probably. So time and then how much room you're trying to cover. So all those things. And then I think Todd had another question. So Todd said, good for the 2x2. Any idea why it's leaking? So I think it's that back pressure. So when I come back out, I probably had my foot on the pedal and didn't. It has back pressure, so it's still gonna push a little bit. So again, if you take your foot off the pedal but keep it in the bone, it's gonna end up probably absorbing in there. You should be fine. So
There's also one thing to say about that as well.
yeah,
The leakage part, like if you think about it, you stop the plunger and it's going to quit advancing the carpule. However, there's still, like you mentioned, there's back pressure, but there's also like it's not going to hold the anesthetic that's in that needle. So if you stop it and just kind of pull out, that what's in that needle is just naturally going to come out. So anytime you quit your injection, one thing I like to tell people is just, hey, stop your injection and then wait a few seconds before exiting. So especially like after the stage one, to prevent the leakage between, stage one going into stage two, stop your injection, just wait a few seconds and then exit the gingiva.
yeah.
So
Just stay there. Let it like kind of bleed through. Let it kind of just like
yeah,
almost like a capillary action, just kind of get drawn out. To have space to go, it's not a perfect solution, but it's, you're going to get a drop, maybe two. That's it. It's not coming from the hub. It's not coming from anywhere else. It's literally like Jordan said, it's what's ever left in that, whatever consolidated drop or two of local is left in that syringe tip is probably what's, just leaking out. So, but yeah, no real solution there. Dr. Wu asks, will you give Powdle lingual instead of buccal? Would it numb the same amount of area? So same thing. If you don't have any buccal bone, you're still going to do the same exact amount in the palate or the lingual side. It's, again, it's what you're trying to do. It's still going to numb the exact same area, exact same everything. You just have to have bone you're putting it in, which is the biggest kind of thing you have to be on top of. Yeah, I mean, we don't really see palatal abscesses. That's really not a thing. Lingual abscesses, everything goes buccally for whatever reason. So you don't really see the other ones happen. So
and Paul, how often are you given intraosseous from palatal or lingual side?
and to answer that question, it really just depends. I mean, I had a couple of cases in here I could have thrown in. I mean, I had a lot to cover, but like we just did palatals for whatever reason because again they had buccal abscesses. So again, if I had my druthers, I'm going to go probably buccal on almost everybody. Now, me being right-handed, working on the upper left quad sometimes a little tricky because I got to hook the whole way around. So from my perspective, doing a palatal on upper left quad technically is probably a little easier and then easier access too. So if you're left-handed, obviously doing the upper right quad, that's going to be your challenge. So you might want to do a palatal over there. See if you get A, more comfortable doing it, and then B, it has the same results. And the kid's obviously as comfortable. That's always an option too. You could, use your contralateral upper side and always do palatals up there if you want. But for the most part, buccal is my go-to, but. Looks like I'm 3 minutes over. That's not too bad. How are we doing otherwise? No more questions? So
Great.
Great. Yeah, no, and great questions, by the way, everyone.
Yeah.
So we really appreciate you asking. If there's any last minute questions, please throw them in.
If you guys need to get a hold of me, please reach out to Jordan or Aaron. Chris, I can readily available. Again, it sounds like Katie's got a new friend in Matt Lucero in Denver. So again, we're here to help. If you guys can come to one of these hands-on things too, it always is helpful too, because, to actually hold your hand and do it is really helpful. If you can take these to the OR, to a surgery center with you and use them, it's really great to, I hate to say this, play with and really get used to. And then obviously chicken bones are really cheap and easy, and you can bring them in and kind of get a feel for that pressure and that force you need to use and try to really work with that. So those are the kind of things you can do outside the office, I think, to really help yourself out and get more comfortable. So.
Yeah, and on that note too, we always say, start in primary dentition and work your way up because it's going to be a lot easier to get into those little bones. I know a lot of people, their first go-to is to go practice on their assistant, but if you can get into your assistant, you're pretty good to go because you're working in permanent dentition, unless you have children assistants, and that's a whole nother thing. But so yeah, start primary if you can, and then work your way up.
And thanks for your time tonight. I blew through a lot of stuff. Webinars are tough, like I said, because you don't have the interaction of what you guys want. But if there's stuff you want from me or something I can answer, or just you want to see some of these cases, just, shoot me an email and I can pass stuff along. But hopefully you guys all have been using this a little bit. You're fairly comfortable with this. And there's always going to be curveballs. And that's the fun stuff to share, because that's how we all learn. So hopefully if you do have some curveballs, loop in Erin, and she can put that kind of stuff on the Facebook page, and then we all can learn from it and just kind of, commiserate and, work through it and learn. So
absolutely. We all get excited when we see something new. We're like, oh, I haven't seen that before. That's awesome. So definitely get on there and post. Also, if you want to go back and look at any of this, they are posted on the NuSmile website. All of our webinars, this one and all of our previous, are posted on the NuSmile website under education and NuSmileTech. So you can always go back and access Dr. Bahn's slides and take pictures or whatever you need to do. So thank you guys. Thank you, Dr. Bahn.
no problem, guys. Do well.